Good day, friends, and welcome to the 34th edition of 4D, which is Detailed Discussion and Dialogue for Indian Diabetics. I am Dr. Sanjay Kalra from Karnal in Haryana. I presently serve as the president of the South Asian Federation of Endocrine Societies. But for me, it is a matter of great pleasure, great pride to be able to connect with you through the 4D platform. It's together that we can work to improve the health, the diabetes care of all our countrymen and women. And these days, the holy month of Ramzan is going on, when around 20% of our adult population fasts. How do we make sure that believers are able to fast in a meaningful, in a blissful, in a healthy manner? To find out, let's invite our guest for today, Dr. Amit Goel. Dr. Amit Goel is a senior endocrinologist, a consultant in Karkhana, Secunderabad, Telangana. He brings with him extensive experience in clinical endocrinology, in research, in academics, and most important of all, in patient awareness and patient advocacy. Warm welcome, Dr. Amit, to the 4D show. It's great having you with us, Dr. Amit. Would you like to speak about the topic for today, which is Ramadan and diabetes? We look forward to learning from your experience and expertise.
Yeah. Hi, I am Dr. Amit Goel, consultant endocrinologist at Endoride Diabetes, Thyroid and Hormone Center, Secunderabad, Karkhana. Today, we will be discussing on diabetes management in Ramadan. So, this being the Ramadan season, it's going to be a very important topic. So, maybe in the next few minutes, we will be taking you through it. Yeah. So diabetes and Ramadan, next please. Yeah. As we all know, in India, 1 in 11 adults is living with diabetes, and over 53.1% of the adults living with diabetes are still underdiagnosed. So this is a major chunk of patients who are still underdiagnosed. And the number of people living with diabetes in India is second highest in the world. So we are the second highest in the world for diabetes and highest in population. So definitely it is not so far where we will be the highest in the world with diabetes also if we do not change our lifestyle managements. So as we know, 40 million adults in India are still having impaired glucose tolerance. So these are the risk patients or they are at high risk of developing type 2. So focusing more on these patients, stopping them at this and maybe reversing their diabetes over time is going to be a very important factor. The rise in the number of patients with type 2 diabetes is driven by an intercomplex of socioeconomic, demographic, environmental, genetic, as well as certain religious practices also. Next, please. As we now know that Ramadan is a holy festival and is being celebrated in this month, is associated with a market change in people's diet, with majority of the adults belonging to the community observing fasting. They have erratic eating patterns and disrupted daily fasting and feasting cycles, which may hurt their glycemic levels of an individual who is doing it. So, in the end, for a person with diabetes, does celebrating Ramadan comes at a price of a good health? That's the question we are going to answer today. And how do we manage the diabetes during the phases, which becomes extremely important for us? Next, please. So, pathophysiology of fasting. So, the patients who are non-diabetic, eating increases insulin production and promotes the accumulation of glucose in the liver and muscle as glycogen. In contrast, insulin production decreases when blood sugars go down during fasting. So, in patients or in people with diabetes, circulating glucose tends to fall, leading to a decrease in insulin secretion. So, after several hours of fasting, the glycogen stores become depleted, and low levels of these circulating insulin allows you to have an increased fatty acid release from your adipose sites, leading to oxidation of these fatty acid generated ketones that can be used as a fuel by skeletal and cardiac muscles. So, thus sparing glucose for utilization by the brain and erythrocytes. Next, please. So, what are the challenges in diabetes management? As we know, diabetes is a continuum and a complex disease. If there is hyperglycemia, there can also be a other continuum of hypoglycemia, dehydration, diabetic ketoacidosis, micro and macrovascular problems, which may build up over uncontrolled diabetes. So, patients taking insulin and other oral anti-diabetic drugs without any dose adjustment during fasting increases the risk of the complications. So, during fasting, physical and mental health alterations also happen, and this happens especially in the elderly comorbid with diabetes, and this puts them at risk of complications. So, due to irregular food habits, some patients may skip their usual medication. Poor monitoring of diabetes complications and blood sugars, particularly in the rural areas, is a substantial risk. Next, please. So, how do we risk stratify pre-Ramadan assessment and risk stratification of our patient? Is all patients with diabetes wishing to fast during Ramadan should have a proper counseling 1 to 2 months prior before the onset of Ramadan. This should include their assessment of a full annual review, detection of complications, along with measurements of HbA1c, blood pressures, and lipids, as well as specific advice, including potential risks of fasting. So, this is an ideal time to suggest any changes regarding diet as well as medications for the treatment of diabetes. So, educational counseling should focus not only on patient but also on his or her awareness of the symptoms of hypo and hyperglycemia, planning of meals, blood glucose monitoring, administration of medications, physical activities, and if any acute complications do set in, when to break your fast. Next, please. So, which are the categories? So, we risk categorize our patients into very high risk who must not fast, who should fast, that is the high risk, and who may fast with risk. So, in your very high risk is one of the more, if the patient is having severe hypoglycemia, history of severe hypoglycemia, DKA, HHS within 3 months prior to Ramadan, we request them not to fast. History of recurrent hypoglycemia or hypoglycemic unawareness is there. Patients with type 1 diabetes, patients who are pregnant and have sugars, that is, or diabetes, have GDM, chronic dialysis patients, old age with ill health, advanced macrovascular complications such as a post CABG, post CAD, or patients with cognitive impairment or uncontrolled epilepsy or uncontrolled fits should not fast. Who must not fast? So who should not fast is type 2 diabetes with poor glycemic control or patients on multiple doses of insulin or mixed insulin, stable macrovascular complications, patients who have diabetes and are a laborer. So physical labor can increase risk of hypoglycemia. Treatment with drugs that may affect their cognitive function. Who can fast is patients who are on lifestyle therapy, who are on metformin, acarbose, incretin-based therapies, SGLT2 inhibitors, basal insulin, have the choice and can fast with the risks involved in Ramadan. Next, please.
The EPIDR study. So this was a retrospective population study which India was also a partner. So the data was analyzed from 12,243 participants, where 8.7% of the patients were type 1 diabetic, and nearly 43% of the type 1 diabetes and 79% of the patients with type 2 diabetes reported fasting for at least 15 days during Ramadan. So the insulin dose was unchanged in 64% of the patients, and the doses of oral medications were unchanged in 75% of the patients with type 2 diabetes. So severe hypoglycemia was significantly more in type 1 diabetes compared to the type 2 diabetes. Next, please. So how do you modify the physical activity and diet? So diet in patients, so there's a Ramadan plate which is usually a concept there. So patients should be advised to avoid food high in fat and sugar. It has been suggested that eating complex carbohydrates meals at dawn, that is at suhoor, and simple carbohydrates at iftar may be more appropriate. So other suggested eating foods with long glycemic index when breaking the fast is also there, like 2 pieces of khajur is what they usually use with milk, glass of milk, when you're breaking fast. So slow energy release happens from foods like grains, wheat, and rice and are best before, that is in the suhoor time and after the period of fasting also. And we also advise that the intake of ghee and fried snacks as well as high fat and sugar rich sweets should be minimized. Now, coming on to physical activity. So, after the night prayer, a part of the customs of Ramadan, most men would normally walk to the local mosque. So, this should be considered as a part of the daily exercise program. And also, we would advise two small snacks after your, iftar before you go to bed and at suhoor, before suhoor, so that the energy intake is balanced all throughout the time. And while normal levels of physical activities are encouraged, excessive exercise during the fasting period might lead to a hypoglycemia and should be avoided. Next, please. So risk stratification, we risk stratify as early initiation of combination therapy and novel medications which are less in terms of causing hypoglycemia like DPP-4 inhibitors, SGLT2 inhibitors and GLP-1 agonists can also be put in patients who are going to fast.
Dr. Amit, that was a wonderful talk. Thank you so much for sharing all these important nuggets of information with us. A question coming from the audience is, now Islam enjoins all adult and healthy believers to fast. So that is taken for granted. But how frequent is it that adolescents or antenatal women, women who are otherwise exempted from fasting, adolescents, antenatal women, and people who are relatively sick, how frequent is it that these people come to the OPD and request for help in fasting?
Yeah. So basically, the old age or elderly do come in and request us for fasting, and also the we have seen a lot of antenatal women do come and request, but it is rare for antenatal women to come and request us for fasting during Ramadan because they're already maybe knowledge according to the things. But as customs, yes, definitely they do come in and ask us for permission, but we definitely deny permissions to patients who are at high risk of developing hypoglycemia.
Thank you, Dr. Amit. A question that has come up is, uh, now, as a physician, as an endocrinologist, you are aware of risk stratification and you've taught us as well. What is the level of awareness amongst religious leaders, amongst the ulema? And how can we partner with them? How can we cooperate with them to spread the message of healthy fasting, meaningful fasting?
So it is very, very important to educate the religious leaders, the ulemas, to partner with us as physicians and endocrinologists in helping the medical care reaching the common, masses and making them educated and aware of hypoglycemia because hypoglycemic risks are very important. We are in conjunction with their religious beliefs. We would help them to minimize hypoglycemia and have a proper fasting state throughout Ramadan.
That was a very insightful answer, Dr. Goyal. Thanks for that. A specific question is coming regarding metformin. So, does it make a difference to dose adjustment if the patient is on sustained release metformin or on immediate release metformin?
Yes. So yes, definitely the sustained release metformin is a better choice than immediate release. So I would prefer a sustained release uh, also, but in patients who are in fasting state, like in Ramadan, we can give the immediate release format in the early morning at suhoor time and also at sahari time. So that's going to improve and not cause hypoglycemic risk, which can be there with your sustained release format also.
We have one question which is related to diabetes, of course, not to glucose control, but the question is about blood pressure lowering drugs. My patient is on a fixed dose combination of telmisartan and chlorthalidone, or telmisartan and hydrochlorothiazide, one tablet in the morning with breakfast. What should I do during Ramzan? Should I tell the patient to break the tablet in half and take it before suhoor? Or should I shift the tablet to after iftar and keep it as one tablet?
So I would rather tell them to shift it after iftar. That would be an option because certain tablets might not be scored, and also the risk of dehydration with the diuretic might be more in patients who are going to do this. Or also I would avoid diuretic if possible and maybe change over the medication.
Another question from the audience is, do we need to change I can take this myself, do we need to change the dose of statins or of anticoagulants? The answer is no, we can continue the same dose. If the patient is comfortable taking it before suhoor, that's fine. Otherwise, the patient may wish to take after iftar. Now, this question is important. The question that is being raised by the doctor is hypoglycemia awareness training. How do we teach patients the symptoms of hypoglycemia? Now, the symptoms of hypoglycemia can be classified as being neuroglycopenic, that means less glucose in the brain, so neuroglycopenic, or adrenergic. Adrenergic means that hypoglycemia has stimulated adrenaline to kick in as a counter-regulatory hormone. So, how do you explain the symptoms of hypoglycemia to an individual so that he or she knows when to break the fast?
Yeah. So if your patient starts feeling sweaty, starts feeling a palpitatory kind of a feeling, or starts getting a fear, phobic kind of a feeling, or a sinking kind of a feeling, within themselves, they can actually they are advised, if possible, to check the sugars, and if the levels are less than 70, they are definitely advised to break the fast and not immediately pop up some chocolate or something. I would advise them to take a glucose powder, that's anhydrous glucose, in 15 ml of water, and then recheck your sugars in 15 after 15 minutes. That's the ideal way. So we do not want them to have any level less than 70 milligram per deciliter on a glucometer, and because these things can harm you rather than anything else.
Thank you, Dr. Amit. One concept that we have, and we use it in North India, it may or may not be applicable to other parts of the country, that is a hetero mix regimen. So in the morning, you give a low mix insulin along with the suhoor meal. That will contain relatively less of bolus insulin. The risk of hypoglycemia is less. But at night after iftar, you can give a high mix insulin, 50-50. This makes sense because usually the iftar meal is very rich. There are a lot of carbohydrates, a lot of simple carbohydrates, no matter what you do, no matter how much you counsel the patient. So, low mix in the morning and high mix at iftar. This is known as a hetero mix regimen, and sometimes we use this in Ramzan.
Yeah, that could also be definitely a good way of doing it. Yes, definitely in the part of the country where we are, South Indian meals are more richer in carbohydrates, and definitely we might try this heteromix regimen as suggested by you, sir.
There is a question about culinary science. And thank you for raising this question. So the point is, what kind of a suhoor meal should you have to ensure that there is minimum thirst and maximum satiety throughout the day?
Yeah. So as we already mentioned, complex carbohydrate meal is a very important meal in the suhoor time. That can be your rice, your high fiber diet, good fruit diet, because the over time, if you look at, that's the fuel which is going to continue for throughout the day for the patient to manage his energy levels all throughout the day. So definitely slow releasing or complex carbs can be very good option in taking your morning suhoor meal rather than a iftar.
That was a great answer, Dr. Amit. Let me add a few words here. Do think of the person who is cooking at home and make sure that whatever sehri recipes you advise, they should be easy to cook with minimum preparation time. At the end of suhoor, try to minimize salt, spices, and sugar, also saturated fat. Because if you drink, let us say salted buttermilk or a very spicy dish, spicy keema, at the end of suhoor, you are going to become thirsty very soon. So whatever spicy or salty or saturated fat rich food you wish to take, that would be best taken after iftar. But after suhoor or during suhoor, it should be things like simple curd, milk, buttermilk, raita. And one recipe which my patients have taught me, I'm grateful to them. That is the best thing you can have towards the end of suhoor would be to have raita with the loki, a very cooling kind of a dish, which will keep you satiated and which will prevent you from remaining getting hungry or thirsty throughout the day. So that would be my personal recommendation. A very cool kind of a raita with minimum salt, minimum spice, and it's guaranteed to keep you happy throughout the day. Thank you, Dr. Goel, for having been with us. Thank you, everyone, for having logged in today. And we look forward to welcoming you again to the next edition, to the 35th edition of 4D, Detailed Discussion and Dialogue for Indian Diabetics. It is dialogue which keeps us together. It is dialogue which will ensure that we are able to ensure better health, that we are able to accomplish better health for all our countrymen and women. Jai Hind, everyone.